nasal cavity to the external environment, and you have a septum at the center. Okay, and inside the nose, on the either side of the partition, you have the spaces on either on the lateral side, and you have a nasal septum which has a membranous part, cartilaginous part, and a bony part. Is that clear? Okay. So normally an adult is estimated to be carrying up to 10,000 liters of air per day. So all the oxygen containing gases, air from the environment, which is needed to your body, which is needed by your lungs, is being shunted only to the nose. Okay. So, so what is the narrowest part of the nasal cavity? Anybody? So it is the nasal valve area. Okay. So nasal valve has an external nasal valve and the internal nasal valve. External nasal valve is nothing but the opening of the nose at the end of the ala and the vestibule. And what is that internal nasal valve? That internal nasal valve is situated just 1.5 centimeter from the anterior end of the septum. Okay, so it consists of an superolaterally. It is bounded by the lower end of the upper lateral cartilage, and the septum in the midline, and still more laterally you have the piriform aperture, which is the bony part of the nasal cavity, which is the starting point of the bony part of the nasal cavity in the lateral nasal wall. Okay, and the corresponding area of the floor of the nasal cavity. So this is the most narrowest part of the nasal cavity, or the upper airway, before the glottis. Okay, this is the most narrowest part. So even the glottis can open it and close. Okay, but this external nasal valve, it is a fixed point. So because it is the narrowest part, that part or the nose contributes up to 50% of the resistance of the entire airway. So any deviation or any change in the dimension of the internal nasal valve has a great effect on the entire airway. Okay. So that is why, and what is the posterior limit of this external nasal valve? This is the anterior end of the inferior turbinate. Okay. So, so any enlargement of the turbinate, any deviation of the septum, or any mass, any polyp occurring in that area, greatly contributes to the nasal resistance. Means any constriction of that part of the nasal valve will contribute to the nasal obstruction. Okay, so you should, while doing surgery, what is the applied physiology in this? While doing surgery, we have to make sure that this nasal valve area is patent always. Okay. Okay. So as a whole, what is the function of the nose? So it provides nasal cavity. It is providing us a physical buffer or a barrier against the injury to the face. Okay, so you know that nose is the most prominent, or the most anterior most part of the face. So it protects the eye, it protects the mouth, and even it is protecting the brain, anterior cranial fossa. Hmm? Okay. Okay. So also that it contributes to the vocal resonance. So what is that resonance? So a sound is being generated in the voice box. So any sound which is passing through an air-filled cavity creates a resonance. Okay. So this our speech produced in the voice box or the larynx passes through the nose and the nasal cavity, so that proper resonance is created. Okay. So the consonants like ba, b, those things, those consonants are very much dependent on the resonance of the nose and the nasal cavity. Okay. Next is the humidification. So the inspired air has to be humidified to the body temperature, so that it remains as a part of a internal environment of the body when it reaches the lung. Okay. And it provides as a heat insulation, air conditioning, and most important is the it acts as a filtration unit, right from the vibria. And since it is a wet area, no, the nose and the nasal cavity is a wet area. So any small particles will get stuck upon the wet surface of the nasal cavity and the paranasal sinuses. Okay. So these are the important functions of the nasal cavity. So, uh, in the coming slides, we will be seeing about the vascular physiology, autonomic physiology, how is the pattern of the airway, how is the pattern of the airway, and how is the pattern of the mucociliary clearance in the nose. So these are all the most important things which are the more which contributes to the normal physiology of the nose. So as you very well know that the nasal mucosa is very vascular. It contains arterioles, arteriovenous anastomosis, and venous sinusoids. Okay, so you very well know that the nasal cavity has sinuses, and you have a turbinates. So what are the use of these turbinates? So this turbinate is not like a straight line. Okay, it has an elevation, it has a depression, like that in your brain, like a sulci and gyri. So there is elevation depression of the lateral nasal valve. Because of this, the surface area is getting increased. So how much area of vascular vessels are there, blood vessels are there? There is about 150 centimeters square of the vascular area is there. So this nose in the paranasal sinuses has a rich amount of vascular supply. That is why in bleeding in the nose can be more severe. And how does it provide with the resistance and the capacitance? So resistance is caused by arteries and arterioles. Capacitance is provided by the venules and the sinusoids. And these sinusoids and the venules and the sinusoids are more common in the nasal septum and the turbinates. So that is the reason you have you know that the turbinate can get enlarged, and okay, yeah. So these venous sinuses form an erectile tissue. It's located in the anterior nasal septum and the inferior turbinates. That's what I'm saying. Okay, and this change in the hydrostatic pressure affects the filling pressure of the vessels. So where increase in pressure expands the venous sinusoids. And how does these vessels are being controlled? By the autonomic nervous system. Hmm? Because of the activity of the smooth muscle, which is found in the arteriovenous anastomosis. So, any change in the autonomic nervous system can cause a change in the caliber of the vessels. Hmm? So, how does this autonomic nervous system supply here? So, you know that there is a parasympathetic fibers, and there is sympathetic fibers. So these parasympathetic fibers originate in the midbrain with the postganglion fibers traveling in the natural tract of the trigeminal nerve. Hmm? So this causes the secretor motor supply the mucosa. So what the region, which along with the canal for the pterygoid canal. What is that name? It is known as Vidian nerve. Okay, and so what is the primary neurotransmitter here? It is the acetylcholine and the vasointestinal vasoactive intestinal peptide, which is present in the saliva also. Okay. So the sympathetic nervous innervation is uh, starts from the thoracic spinal nerves with the preganglionic fibers synapsing the cervical sympathetic ganglion, which is in the neck. Okay, and these postganglionic fibers travel alongside the internal carotid artery and supply the vasculature. Okay, so what is the primary neurotransmitter here? Is the noradrenaline. Okay, so adrenaline soaked pack, which is kept, which can be kept in the nasal mucosa, can cause constriction of the blood vessels, thereby reducing the size of the carbonate. So we normally use adrenaline soaked gauze, adrenaline soaked cotton, cotonoids. We will use during surgery to decongest the nose. Okay. So next comes the epithelium. So you know that three kinds of epithelium are there in the nose and pharyngeal sciences. So one is the squamous epithelium, which is present in the nasal vestibule. So vibrissae, sweat glands. Okay, and second is the pseudostratified columnar epithelium, which covers the 2/3 of the posterior nasal cavity. So you both have a ciliated and a non-ciliated columnar epithelium cells, basal cells, and also the mucosecreting goblet cells. So goblet cells can also be seen in the middle ear. So third is the olfactory epithelium, which is responsible for the smell. So where does it situated? It is situated in the superior medial portion of the superior turbinate, or otherwise the roof of the nasal cavity, which separates the anterior cranial fossa. Where is that? It is at the cribriform plate. From the cribriform plate, it spreads along the roof of the nasal septum and the portion which is superolateral to the superior turbinate. So what are the kinds of cells you can see there? You can see Bowman glands and ducts and bipolar receptors and sustanacular cells and microvillar cells. Just next, coming to the cilia. So it's an important question for you, and ultrastructure of cilia can also be asked for you, which is nothing but the same 9+2 pattern of the microtubules. So how does it arrange? It is arranged in a 9 outer paired microtubules, so which encloses a single inner pair of a microtubules. Single inner pair of microtubules surrounded by 9 outer pair microtubules. These outer pairs of the microtubules are linked to one another by nexins and to the inner pair of the microtubules by central spokes. Hmm? And these outer pairs of the microtubules have both outer and inner dynein arms that are made up of ATPase. What is the use of this ATPase? Since the cilia has to move, so any movement or a kinetic energy is needed. What do you need? You need an ATP. For the creation of the energy, ATPase is needed for conversion of ATP to ATP. Okay, so normally at body temperature, cilia can beat uh, 7 to 16 hertz per minute. Okay, the frequency usually remains constant. And the temperature is between 32 and 40. And the cilia can beat rapidly in a propulsive stroke or slowly during the recovery. Hmm? Okay. How does this mucociliary transport is being done? That will be discussing in the mucosal blanket. Uh, topic. Okay. One second. Okay, so these respiratory cilia are extremely effective in transporting the mucus trapped inhaled particles and bacteria at the speed of 3 to 25 millimeters per minute. So the beat is normally about 12 hertz. So another important thing what you should know is a substance called nitric oxide. So it has more physiologic functions like bacteriostasis, or it can stimulate the ciliary beat rate. So it is produced remarkably in large quantities in the maxillary sinuses. Okay, apart from other sinuses. So how do they relate? So if there is increased concentration of nitric oxide, the ciliary beat frequency is high. Okay. So whereas it is low in ciliary dysfunction. Here, if this nitric oxide is very less in number, less in concentration, ciliary dysfunction can occur. Okay. That is why smoking or primary ciliary dyskinesia, and these cases you will have less amount of nitric oxide. Okay. Next, coming to the mucosal blanket. So you very well know that the nasal mucosa is made up of ciliated columnar epithelium. So above the cilia, we have a slimy layer. Okay, this when seen through an electron microscope, you can see two layers in that slimy layer. One is in the gel phase, another one is the salt phase. Okay, gel phase is nothing but the mucous layer. Salt phase is nothing but your serous layer. Okay, and this gel phase is the outermost area. This salt phase is having a contact with the cilia, tip of the cilia. So what will happen? Any microorganisms which is stuck into the gel phase can be moved towards the other direction, okay, by the movement of the cilia. Okay, by having an effective stroke and a slow recovery stroke. So what will happen in the effective stroke? The extended cilia reaches the mucous layer. Okay, while in the recovery stroke, they bend and travel and slowly comes to the serous layer. So this happens not in a continuous manner. So if everything is happening in the same frequency, then there won't be any movement. No. So each layer, each area of the cilia will be moving in different phases. Okay, but cumulatively, what will happen? This there will be a transport of the microorganisms or whatever the secretions from the sinuses can will be moving from one area to the other area. So, okay. Next is the airflow pattern. So you will know that, and we have already discussed that the most constricted part of the nasal cavity or the nasal airway is the nasal valve area. Okay, so during inspiration, the air flow in the nasal up to the nasal valve area will be an laminar airflow. So what is the laminar? It's nothing but air passing through a straight line. Okay, that is known as laminar flow. Okay, once it crosses the nasal valve area, internal nasal valve area, this airflow will not be a laminar flow. Okay, then what happens? So after that constriction point, what you can see? You can see you have a big nasal cavity consisting of numerous depressions and elevations. That is known as turbinates. So because of this kind of depressions and elevations, because of the irregular nature of the nasal cavity, the laminar flow is changed into a turbulent flow. Okay. So what is the use of this turbulent flow? Because of this turbulent flow, the air can pass through each of the depressions and elevations. Okay. So the laminar airflow is changed over to a turbulent airflow during inspiration. So because of the turbulence, what will happen? These inspired air can reach all the crevices of the nasal cavity, so that an effective filtration is being done, an effective humidification will be happen. Okay, so the same thing happens in the expiratory flow. So what happens extra in the expiratory flow is there will be formation of eddy currents in the floor of the nasal cavity. Okay, so this you should know in physiology. Okay. Next is the patterns of the drainage. So what we have discussed, we discussed about the epithelium of the nasal cavity. We discussed about the what is the structure of the epithelium. We discussed about the cilia of the epithelium in the nasal cavity. So these cilia or the nasal mucosa is lining the all the surfaces of the nasal cavity and the sinuses, which is which is not an regular cavity, it is an irregular cavity, no. So all the secretions, all the secretions from each sinuses has to get drained into that nasal cavity. Okay. After that, it has to drain into the nasopharynx. After that, it has to drain into the uh, throat or the pharynx, so that we will swallow and it will go into the digestive tract. Okay, this is a normal pattern. But to reach nasal cavity from each sinuses, there should be some kind of mechanism, no? Because when you see the natural sinus, you see there is a flow, there is a roof, there is a medial wall. So any pest or any microorganism or any mucus secreted by the goblet cells, it has to reach the nasal cavity. It has to reach the nasal cavity through the natural ostomy. What is the other name of natural ostomy? The maxillary antrum. It is situated in the medial wall of the nasal cavity, particularly in the hiatus pulmonaris. Okay, so if a mucus has to reach to the natural ostium, how should the pattern of the drainage be there? From the nasal cavity, from the maxillary sinus, all the mucociliary bead will be directed towards the natural ostium. So what is the pattern called? That is, the pattern is called a stellate pattern of drainage. So similarly, when you see the frontal sinus, you have a drainage of pattern of, first the mucociliary bead will be moving towards the medial end. Okay, so what you see here is the, what you see here is the two frontal sinuses. Okay, so each frontal sinus pattern of drainage is like the medial end of the frontal sinus will be directing towards the superior surface, and then it has to move to the lateral surface and comes to the floor of the frontal sinus. Then finally it drains into the frontal recess. So what is the kind of drainage here? It is known as active inward drainage. So another type of drainage, or another type of phenomenon is known as bridging phenomenon. This you should know. So this occurs particularly in the ethmoid cavity. So how does the ethmoid cavity look like when you have a cross section? It is like a honeycomb-like structure. No, it is an irregular structure inside it. So any secretion here has to move across numerous depressions and elevations in microstructure level. Okay, so here what will happen? So if there is a discontinuation of the mucosal blanket, or if there is a considerable amount of gas, this bridging phenomenon can happen. So this mucus does not need to go till the deepest part of the uh, ciliary membrane. Okay, this can bridge to the other end of the elevated part of the nasal mucosa. Okay, so stellate pattern you should know, active inward pattern you should know, and bridging phenomenon you should know. Okay, so next is the function is the olfaction. So you very well know nose is meant for smelling. Okay, so you have a sensory receptor. What is the sensory receptor? This is the peripheral process of olfactory cell. This is the mucosal surface, as I said in the ethmoidal roof, and is expanded into a ventricle with the several cilia on it. So you can have, you will also have a cilia in it. And these central processes of the olfactory cells are grouped into a olfactory nerves, which pass through the pubiform plate of the ethmoid bone. And where does it end? It ends in the olfactory bulbs, particularly at the mitral cells. Okay. From the axons of the mitral cells, they form the olfactory tract, and they carry the smell to the pre-piriform cortex and the amygdaloid nucleus. Okay. So as a whole, what is the function of the nasal nose and the nasal cavity and the sinus? It is elaborated here. What are those? Phonetic. So it creates a resonance. It protects the speech. And in the respiratory section, it causes the humidification. It buffers the pressure changes, and it also acts as a local immunogenic defense, just like what I said, what we have discussed now, from the vibriae to the mucosal layer. Also, to make a note that even IgA antibodies can also be seen in the mucosal layer. Okay, that contributes to the local immunogenic effect. Then the olfactory function by supplying the olfactory fossa, and this gives an air reservoir of stimuli. And static, it reduces the skull weight because air is filled in the nasal sinuses, no? So because of that, it reduces the skull weight and the mechanical trauma protection. So nose is the foremost or the anterior most part of the face, no? So it protects the eyes, brain. Okay. So thermal heat insulation by humidification. Okay. These are my reference. If you have any doubt, let me know.